Good evening, everyone. My name is Jennifer Lombardo, and I work for Rothman Orthopedics in the marketing department. I just wanted to take this time to thank everybody for joining us this evening. We normally do these lectures in person, but under the circumstances, we've been doing a lot of virtual lectures, which have actually been pretty helpful. A lot of people have been finding the content very useful. We are also going to record this presentation, so I will send it to everybody afterwards, and you can rewatch the information, or you can forward it along to anybody else that may benefit from the lecture as well. This evening's lecture is going to be given by Dr. Arjun Saxena. Dr. Saxena is one of our joint replacement surgeons here at Rothman. Dr. Saxena sees patients out at our Mercerville, Pennington, and Princeton, New Jersey locations. His topic he will be speaking on this evening is living with hip and knee arthritis during a pandemic. Now what? Just a reminder, I am going to keep everybody muted during the presentation just to avoid interruption. If you have any questions, please type them into the chat section at the bottom of the screen, and then Dr. Saxena will get to all questions at the end of the lecture. All right, Dr. Saxena, are you ready?
So let's get to it. I look forward to answering questions at the end. So a little bit about me. I went to I'm from Philadelphia area, Bucks County. I went to Penn State for college. I went to Jefferson for medical school, and I stayed there at the Rothman Institute for a residency in hip and knee replacement. And I did a fellowship outside of DC at the Anderson Clinic in hip and knee replacement. I've been in the Mercer and Bucks County area for about 8 years now, and really enjoyed caring for the patients in these communities. So, you know, on this, when we have talks like these, most people know someone who has had a joint replacement, but I can guarantee you everyone knows one of these people, and all of them have in common the fact that they've had a hip or a knee replacement. So it's a pretty common thing, affects people from all walks of life, and arthritis is really rampant. I actually read an article the other day that said musculoskeletal complaints were number one, basically, in the amount that they cost our society and the amount of times people go to the hospital. So as we age, our joints and bones ache. As we do silly or sporting events, our ligaments tear, our bones break, and things like that. And so musculoskeletal care is a really important thing. And so I'm really happy to be a part of that. So the first thing I wanted to talk about was a little bit about hip arthritis. Basically, this is how the hip works. I hope you guys can see the mouse I have on here. Looks like somebody's got a dog that's interested. You know, before we get to the anatomy of the hip here, I may have some interruptions. If anybody's been working from home, they may have had their... Oh, they're just coming. They may have had their children interrupt some of their calls. So, yeah, I have two little critters, 3 and 5, that may run down here at some point. Anyway, so here is the hip joint right here. You have your femur or your thigh bone, the ball on top of that, and the pelvis is the socket. And so it's basically a ball and socket joint. And one of the most common causes of hip pain is arthritis. It's a wear and tear condition that degenerates the cushion in your joints. And that cushion is a substance known as cartilage. What usually happens in the course of arthritis, it's a degenerative, so it's something that won't get better over time and usually gets worse. You can develop hip arthritis through abnormal anatomy. Maybe you had a problem with your hip as a kid or as an infant. That can lead to dysplasia and hip arthritis as an adult. Abnormal biology. There was a picture of Bo Jackson. He developed a condition called avascular necrosis, where the blood supply to the femoral head had died. And that can lead to a degenerative hip. Overuse, just a general, life that's active, and that can cause arthritis. And then genetics. A lot of times we talk to people and diagnose them with arthritis, and they say, oh, yeah, my brother had a hip replacement a couple years ago, or, yeah, my mom had a lot of arthritis when she was older. So it's pretty common in a lot of different ways to develop arthritis. So again, at the end of each bone, that's even like your little finger bones, there's a substance covering it called cartilage. And when that cartilage rubs against other cartilage, it moves like a nice, smooth articulation. When you have arthritis, that cartilage actually wears down, and that deteriorates the natural cushion, and that leads to bone-on-bone contact, soreness, pain, swelling, dysfunction. And so the best analogy I like is talking about a door hinge. So this is a brand new door hinge in a brand new building. It's like healthy cartilage. It's well lubricated, and there's full motion. But we take normal function for granted. Getting in and out of a car, just walking, just sleeping through a night without pain. These are things we take for granted. And when you have arthritis, these things can all be challenging. So here's an example of an arthritic joint. This is like a rusty door hinge, and there's no lubrication to it. The cartilage is damaged and there's no motion. And, you know, it creaks and it cracks. Like some of your joints might make noises at times. And so that's a really good analogy, I think, of what an arthritic joint looks like. And so when we talk about hip arthritis, you know, there's some things we ask people when you come to the office. The number one thing I ask is, do you have any trouble putting on socks and shoes? One of the telltale signs of hip arthritis is a loss of range of motion. And so a physical exam can really give you a good idea about how bad someone's arthritis is. Sometimes people will limp. An important thing is, does the arthritis or pain or dysfunction limit your activity or your lifestyle? Sometimes the leg can feel shorter. And then hip pain, interesting, if you have arthritis in the hip, you can actually have pain in the thigh, the groin, the knee, or the butt. So it's not always located right in your hip. And so that sometimes also makes it challenging for patients to understand what's actually hurting. So what can you do for hip arthritis? Well, you can do heat or ice. You know, those are kind of standard things when our joints are hurting. Exercise and physical therapy are really good for an arthritic joint. And also for weight loss, which is also good for an arthritic joint. And that's a place, you know, in this pandemic right now, when people are quarantining, they're not getting to the gym, they're not getting outside. And hopefully it's a little nicer now and people are getting a little more confident and can at least go for a walk outside and, you know, wear a mask, take the precautions. But that's something that I think patients have struggled with is, you know, the COVID-19 and not the illness, the weight gain. I myself got the COVID-6 and have worked off 4 of those so far. Medications, anti-inflammatories, Motrin, Aleve can help your hip pain, and injections, steroid injections can help the hip pain as well. So COVID-19, okay, what is it? It's a virus, okay? And the virus causes a respiratory illness that's transmitted from person to person. I think if you've watched the news, you probably already know all this stuff. Symptoms can include fever, cough, and shortness of breath. So how bad is it? And this is the real confounding factor with this disease for the medical community. There are people who have it and are completely asymptomatic, and there are others that develop severe pulmonary distress and have to be put on a ventilator and can even die. And so right now, of course, there is no cure. We have a number of companies trying to develop vaccines, but that does take time, and it has to be tested on, you know, animals and humans and go through the whole process. So that does take time. So how can you avoid COVID-19? So standard precautions, things you've been hearing this whole, you know, the last 3 months: washing hands, avoiding contact with people that are sick, you know, wearing a mask, and then, you know, quarantining and following government regulations are ways to avoid it. There's, you know, everyone's, you know, at risk of getting it, but who's really at risk of kind of having that on that spectrum, whether it's the asymptomatic or the really bad pulmonary distress or compromise? The people who are really at risk of ending on that more severe end of the spectrum are the immunocompromised, people with pulmonary disease like asthma or COPD, and elderly patients and nursing home patients. And so what should you do if you think you have COVID-19 or were exposed? You want to contact your doctor. You don't want to go to a hospital. You don't want to go to an ER. You want to contact your doctor first. Typically, the first thing they're going to do is order a test. There's a lot of places where you can drive through and get a test without exposing an entire ER or a doctor's office. And then you can kind of work from there at that point. So, you know, now you have hip arthritis, you have hip pain, and you're in this pandemic, and maybe you know you have arthritis or you're not sure what's going on, but how do you figure this out? You know, you're supposed to quarantine. But if you need to go to a doctor, you know, we're all in this together. So doctors' offices, especially the Rothman Institute, we're taking a lot of health and safety measures in our offices. So, you know, social distancing, that's 6 feet apart. If you're going to the grocery store, you know, you see those marks on the floor of where to stand. We have the similar things in our offices, and most doctors' offices do too. There's a lot of screening, so you're going to get asked the same question over and over again when you go to different places. Have you had a fever? Have you been sick? Have you been in contact with anybody that's sick? You know, those are the standard questions. Just answer them. Plexiglass barriers, you're going to see a lot more of those kind of, I think, all over the place, not just in doctors' offices. But those are going to protect people basically from other people, you know, getting exposed to this illness, which can really be transferred by, you know, coughing or sneezing or, you know, just coming in close contact with another person. Cleaning, I mean, this is huge. So, you know, we're taking precautions, and I think you see this even in the grocery store. People are wiping down surfaces when you do the checkout counter. Target's doing the same thing, and so is the Rothman Institute. So the rooms are being cleaned, the chairs are being cleaned. There's a lot of cleaning that's going on, and that's hopefully going to protect people from transmitting the virus through contact surfaces. PPE, protective personal equipment. This is huge. This is how we protect healthcare workers and even people who aren't in healthcare from transmitting or contracting illnesses. And so I'll have another slide on that one. And then finally, we've had to educate our employees. And, again, if you watch the news, most people are probably somewhat educated on this already, but it's about self-reporting. So if you've been in contact with somebody that has it or that's been sick, you want to let people know, you want to let your managers know. And so our employees are doing that. So some employees have been asked to stay home for 14 days because we think that if you don't show symptoms in 14 days, you're probably not going to have COVID and you're probably not going to transmit it. So these are just some of the measures we're taking in our offices. And I think you'll see this in a lot of places, other doctors' offices and even stores and even some restaurants and stuff like that too. So it's important to just understand that these are there for your protection. And sometimes some of it can be a little annoying and just to be patient as everyone's just trying to work together to protect everyone. So personal protective equipment, you've heard a lot about this in the news. There's a big shortage of this when this really first hit America. And I think we've gotten to a better place with it. I'm not sure I'll ever be comfortable that we have enough. And that's part of the reason for the change in the way we practice the stoppage of surgical care, because we wanted to make sure we had enough equipment to protect the nurses and the doctors that have done such a great job caring for these people. So on your screen's left, you'll see what is an N95 mask. This is a mask that should reliably protect you, if you're wearing it correctly, from viruses or other illnesses to transmit into your nose or your oral cavity. And then on the right, you'll see basically a whole getup. So there's a spacesuit, there's a face shield, there's boots, there's gloves, there's eye goggles. All these things are things people wear in the hospital and in other healthcare facilities to protect themselves from the virus. And these things are not comfortable. If you're wearing these for a long time, they can get really hot. The masks can make marks on your face and make it hard to breathe. So it's a real challenge, and I give a lot of credit to all the people who are literally sitting there 10, 12-hour shifts caring for sick patients and having to wear all this stuff. So now we've gotten through the doctor's office part. Let's say you've been to the doctor's office and you've decided the non-operative things haven't worked. And when do you decide that? Basically when the pain and dysfunction from your arthritic hip cause so much pain and dysfunction that you just don't want to deal with it anymore. Hip replacement's a great option for those people, and it helps relieve pain and improve mobility. It's pretty common. Hundreds of thousands get done in America every year. So how does it work? Well, on your left here, you see the screen that we saw initially, the femur, the thigh bone with the ball on top of it, and then the socket. That's the ball and socket joint. And a hip replacement here just recreates that. So we put a metal stem inside the femur, a metal shell inside the acetabulum or socket, and then a ball and a liner articulate to recreate that hip joint. So here's what an arthritic hip looks like on the left, the pre-op picture. And here's what a replaced hip looks like right here. So you can see basically this shell is in the acetabulum, and then there's a ball articulating with it. And this stem is actually inside of this bone, the femur. So one thing that we're doing that's a little newer is called the anterior approach. If you know anyone that has had a hip replacement, a lot of people will have the incision on the side or towards their butt. The anterior approach is an approach where the incision's made on the front of the leg. And the nice thing we can do here is we can work between muscles and tissues without cutting them from the hip or the thigh bone. So in a classic hip surgery, the patient's laying on their side or could be on their back. But with the anterior approach, basically you use this torture device here, this traction table. Don't worry, you're under anesthesia, you won't feel this. And basically we can use the spars over here to manipulate the leg and allows us to access the hip joint. Also allows us to use x-ray to check the components while we're in surgery. It's actually a pretty old procedure. It's been around in France for a long time, and in the early 2000s it was brought to the United States and popularized, and it's a great way to do a hip replacement. So there's a little less trauma to the body, and there's a potential for faster recovery and some fewer restrictions. So it's a great way to do hip replacement surgery. So overall, though, with hip replacement, regardless of the approach, it's a very good surgery because patients are often very satisfied. Some of our happiest patients are hip replacement patients. And when a patient tells you that, sometimes they don't even remember that they had a hip replacement, that just tells you how great the surgery is. And it really gives us a lot of satisfaction to a surgical team to be able to provide someone with that type of pain relief and mobility. So in summary, regarding hips, the leading cause of hip pain is osteoarthritis. It's a degenerative condition that won't get better over time and will usually get worse. It's important to get a diagnosis so that you can use the treatments, whether it's pills or injections or therapy. And hip replacement helps to relieve pain and improve mobility. So I was going to move on to the knee, and we'll talk a little bit more about COVID here too. So the knee is a bone with joint with three main bones: your femur here, your tibia here, and your patella here, your kneecap. It's the largest joint in the body, and we often call it a hinge joint because it flexes and extends, but it actually moves in multiple planes. Again, knee arthritis is one of the most common causes of knee pain. Same thing as the hip. It's a wear and tear condition where the cartilage or the cushion in the joints breaks down. So when we ask people about their knee pain, we ask, how often does your knee hurt? Nighttime pain is very common in knee arthritis. Just walking distances can be difficult. Pain medications, mainly Tylenol and anti-inflammatories, if they aren't effective, then that means the pain's getting worse. And then the big thing again is, does pain limit your participation in activities? Is it limiting your quality of life? And inactivity from knee pain can actually cause people to gain weight, and that's usually a sign people need to consider aggressive treatment. And that's, again, with COVID, we talked previously about the weight gain. I think that the quarantine, the limited activity has probably had some people put some pounds on, and that really affects your knee joint. And so that makes the symptoms much worse. So how can you treat knee pain? Again, heat and ice packs are great. Medications like anti-inflammatories, Tylenol. We do not recommend narcotics for arthritic knee pain. That's a bad idea. Exercise and physical therapy are great. Physical therapy is usually one of my first lines of treatment when people are diagnosed with knee arthritis for the first time. Also, again, good for weight loss. For every pound you weigh, it's 7 pounds of force on the knee. So even a weight loss of 5 to 10 pounds, which doesn't seem like much, can make a difference in how your knees feel. And then with knees, we can do steroid injections. It's like cortisone, just like in the hip, but we can also do hyaluronic acid or viscose supplementation injections. These are synthetic joint fluid that can be injected into the knee, and these can alleviate pain and reduce symptoms. So again, here we are in this pandemic. This is the HMS Comfort headed into Manhattan, right in front of the Statue of Liberty. A pretty, I would say, iconic picture of what we've gone through in this country in the last 3 months. So what about surgery? Should you have surgery during a pandemic? And there's, a lot of great minds, especially Jay Parvizi, one of my mentors and leaders here at the Rothman Institute, came together and tried to give the rest of the world a guide on what we should and shouldn't do in COVID or during COVID. And it's a really tough thing because this is a new illness. So it's probably a little frustrating because sometimes policies seem to change week to week or even day to day. So the team that Dr. Parvizi assembled did a great job of putting together some guidelines, which actually have remained pretty true throughout. So that's been nice that this has been consistent. So, when should you have surgery? Really what you want to see in your area, this is going to vary by region. So to be honest, right now in the Jersey, Philly, PA region, cases are declining. So this is a time where, okay, maybe now it's getting safer to do surgery. And we've been doing joint replacements here at the Rothman Institute since sometime in early to mid-May. As cases have declined in our facilities. So you want cases to be going down, the number of cases to be going down, and additionally you need hospital capacity. So you need your hospital to actually have beds to care for the patients after surgery. And so the next question was, if I have COVID, should I have surgery? The answer is no, the short answer. The longer answer is we're not 100% sure what it means, especially if you're asymptomatic. But there have been enough bad outcomes in patients who have COVID, who had to undergo surgery, patients who had traumas or things like that, that we're really just not operating on COVID patients at this time unless it's an emergency. So what precautions are taken prior to surgery? And the list is long and extensive, but as far as ones that directly affect a patient are the screening, which I mentioned earlier. You're always going to be screened anytime you enter a healthcare facility, and then the testing. So most facilities will have a policy on testing patients coming into the facility for non-emergent procedures. And so that's something that, again, is a little frustrating. You may have to go to a facility for your pre-admission testing like 2 or 3 weeks beforehand, and then 2 days beforehand go back just to get a COVID test. But it's a way to keep patients safe, and also our staff. If a patient comes in and tests positive for COVID and gives it to the staff, the nurses, the doctors, the anesthesiologists in the rooms, that could be problematic for the whole system because now those people aren't available to care for patients. What about during surgery? What safety measures are taken? Well, even without COVID, we're really promoting a sterile environment in any surgical field. So there's a lot of safety measures to reduce bacterial and viral load. But specifically, more attention than ever is being paid towards this. And so, there's new cleaning protocols where, you have to wait a certain amount of time before you can actually get into the room once it's been cleaned. And some of that is to let respiratory particles filter through using filters and pressure systems in the OR. Next, PPE for staff and the patient as well. Most staff members in the operating room are wearing N95 masks, and previously we didn't usually put masks on patients, but now we are doing that as a pretty standard measure. Anesthesia concerns. You can imagine that if a disease is spread through your nose and your mouth and the secretions from there, that somebody sticking a tube in your nose, down your throat for anesthesia to intubate you would be at risk. So, for orthopedics, especially in joint replacement, we usually prefer regional or spinal anesthesia, and that's even more so in this time. Instrument cleaning really hasn't changed. It's pretty standard. But another measure is decreased case volume. So we're really just trying to make sure that we don't bring too many people into one place at the same time. So, for example, when you leave the operating room, you go to a recovery area known as a PACU, post-anesthesia care unit. We don't want to jam that with 14 patients if it's a 16-bed unit. So but in order to do that, we have to limit the amount of patients and cases that are coming to the PACU. So that's one way that decreasing the amount of surgery we're doing in facilities is also helping with social distancing and preventing the spread of infection. So back over to kind of knee replacement, when you have knee arthritis and you've kind of done all the non-operative things to alleviate your pain and improve your function, and if they're not working, a knee replacement's a great idea. Basically what you do is you have implants that replace or resurface the damaged bony surface. Very common again, probably this slide's probably a little old, there's probably closer to 1 million knee replacements done in the United States every year. So how does it work? So basically, you cut a thin portion of diseased bone and cartilage off of the bottom of the femur and the top of the tibia, and you put metal components just like this picture here. It's hard to see on this slide, but there's a little plastic piece that's white between these two pieces, and that's going to sort of act as your bearing surface, and that's where the joint moves. There's also typically a plastic piece placed on the underside of the kneecap as well. So again, life in a pandemic, what can we expect if we have surgery? So what safety measures are taken after surgery? Well, we try to minimize the hospital length of stay, and we usually do that anyway. Usually you're in the hospital one night. Sometimes you can go home the same day, but we're really stressing that even more now. A big thing, again, is we're doing this most of the time anyway and recommending people go home after surgery because they tend to do better and have less complications. But now with what we're finding is that COVID has really taken over in a lot of rehab or long-term care facilities. So we're strongly recommending none of our patients go to rehab facilities unless it's absolutely necessary. So usually we're probably somewhere around 3 or 4% going to a rehab facility. Now it's probably down to 1 or hopefully even 0. Additionally, we're using telemedicine and digital health. I'm sure you guys have heard of telemedicine, maybe even had a visit with someone at the Rothman Institute or even your own physician. This is helpful for patients, the post-operative patient, if they call and maybe they're worried about their wound or there's a lot of swelling and they just want to talk to their doctor, as opposed to coming in, which is usually what we recommend. People come in to be evaluated. With social distancing, people may be fearful of coming into the office or unnecessarily exposing themselves. We can do a telehealth visit and we can look at you on the screen of our computer and say, oh, no, the wound looks fine, or, oh, the wound, maybe I need to take a closer look. You do actually need to come in. But if it can save the patient that trip, save the person driving them that trip into the office, that's helpful. Again, social distancing, as I mentioned, in the recovery area, keeping everybody apart is helpful. Same thing on the hospital floor and then in the office as well. And then physical therapy. Physical therapy is, in my opinion, a really important part of recovery after knee replacement. So a lot of physical therapy places are taking a lot of precautions. Again, minimizing the amount of people in the clinic at one time, a lot of cleaning of surfaces and personal protective equipment. So it is safe to go to a physical therapist at this point. So back to knees, the summary of knee arthritis, in summary, knee pain, one of the leading causes is osteoarthritis, which again is a degenerative condition that won't get better and will get worse over time. Early diagnosis and treatment is really key. Seeing your doctor, getting that x-ray, which is really all you need to diagnose hip or knee arthritis typically, and using anti-inflammatories, injections, therapy, all those things can help alleviate and mitigate the symptoms. So what can you expect after a joint replacement? I think in kind of relaying everything over to COVID, we've talked a little bit about it. You know, the hospital stay is probably going to be either you could go home the same day or go home after one night. Recovery itself, everybody's different in kind of how they define that. You're going to walk the day of surgery with a physical therapist, and we're going to make that possible by controlling pain, controlling nausea with different types of medications. So a big key to your recovery is walking and working early with physical therapy. Everybody's different in how they recover. You know, a normal kind of where you kind of feel more functional and back to normal, somewhere between 4 and 12 weeks. But again, everybody's different. Return to work. That really depends on your job. If you're, you know, someone who sits at a desk all day and can work remotely, which I think a lot of us have found during this pandemic, a lot of us can work remotely, you could probably get back to work in a few weeks. If you're somebody who's doing heavy labor, operating heavy machinery, it may take some more time, like up to 2 or 3 or even 4 months. The number one thing I can say to tell everybody, you know, how do I avoid a joint replacement? And the best ways to avoid it are to stay active with an exercise program and to control your weight. So many studies have shown that, you know, increased weight is a direct correlation to an increased chance of needing a hip or knee replacement as we age. So weight control and staying active are important. And that, you know, again, comes back to COVID. We've been cooped up in our homes, our gyms are closed, our pools are closed, or maybe they're opening now, but it's really important to get back to physical activity and a healthy lifestyle, obviously in a safe fashion with a healthy fear and respect of an illness that's really taken a lot of lives and affected so much of the world today. So that was all I have for you. I would love to entertain any questions. Jen, were there any in the chat?
Yes, there were a couple questions in the chat.
Okay. I can try to address those. So let's see. Hopefully the person that can see me but doesn't have sound now has sound. So that would be important. I got a We Are, so thank you. We Are Penn State. Question number 1 from Barbara is, does Rothman offer robotic-assisted full knee replacement? And if so, does using robotic-assisted surgery reduce the size of the incision? Yes, at some of our facilities, we do have robots, which are aids essentially for surgeons to perform knee replacement. The surgeon's still doing the surgery, but the robot can help us decide where to make cuts and help us to make cuts on the bone. But just to be clear, the robot is not doing the surgery. Robotic-assisted surgery has been around for probably over a decade at this point. It doesn't tend to reduce the size of the incision. In fact, some might argue you need an extra incision or 2 to do a robotic joint replacement. So typically, it's not associated with a smaller incision. There hasn't been any data to show that there's any better outcomes, but certainly it's been proven to be equivocal to or equal at least, if not, or equal to kind of manual surgery. So it's a great way to do a hip or a knee replacement. It's not necessary though. Next question was from Brenda asking, what if it's too painful to exercise? What can you do? And that's the challenge, right? I mean, it's almost like a contradiction. I'm saying, hey, you have a bad knee or a hip, but stay active and exercise. Well, once it becomes too painful, then that's the challenge. And that's the sign that it's probably time to be a little more aggressive with treatment. So if you haven't had injections, probably time to do them. If you've had injections, might be time to consider surgery. Michael, who I recognize, Michael, great to have you on here, Michael. If anti-inflammatories are contraindicated for gastrointestinal reasons and Tylenol is ineffective for pain management, what are alternative meds for pain? So I mentioned before medications you can take for pain control in arthritis. NSAIDs are anti-inflammatories like Motrin, Tylenol, Aleve, diclofenac, Mobic. They're all kind of the same class of drugs. But for any number of reasons, you can be precluded from taking those medications. One of which is they can cause problems in your stomach, like give you ulcers. They can also cause high blood pressure by damaging your kidneys. And so if those or you might be on a medication like a blood thinner that actually doesn't interact well with those medications. And for those patients, it's really difficult because those medications are really good at controlling pain in the setting of arthritis. Tylenol's okay, not as good. And then the problem is there aren't really any other great options. You certainly don't want to be taking narcotics before surgery, and you don't want to take narcotics to treat arthritis. And so for those patients, unfortunately, they may be pushed to surgery faster because those treatment methods aren't available to them. These are great questions, by the way. From another patient, is repair and replacement indicated with RA? And with RA, does the body attack the new joint? In case you don't know, someone's asking about rheumatoid arthritis, which is an autoimmune systemic arthritis, which is another common cause of knee and hip degenerative joint disease. With RA, the body does not tend to attack the new joint in any more so than any other patient. And really, these implants are inert, so the body doesn't typically attack them. Will you get arthritis in the new joint? You won't have arthritis per se between the bony surfaces because the bony surfaces have been replaced. So in that respect, surgery cures arthritis. In another respect, your soft tissue around your joint, your synovial tissue, has arthritis as well, and that is not replaced in a joint replacement. So our joint replacement patients still have arthritis. The hope is it's just not, adversely affecting them or causing dysfunction. But one thing people will note is even after their joint replacement, sometimes they'll say, I know when it's going to rain or cold and damp weather, my knee gets a little achy and I'm moving okay, but it's achy. And you can take some anti-inflammatories for that and that's fine. So hope that answered your question. To another question from Barbara, what brand knee replacement do you recommend and why? Plastics versus titanium, which do you recommend and why? I don't really recommend a specific brand of knee replacement. What I always tell people is basically it's like Ford and Chevy. There's a lot of different brands out there and they all work and they've all proven to do well. The ones that don't do well and fail are gone. And if there was one that was better, all of the companies would copy that one and then you'd still have all kind of the same. So they're all good. The key really is to get a surgeon you trust and tell that surgeon to kind of do what they do, because there are little nuances that are different between the implant systems. And so if you're doing an implant system that you're not familiar with, it does make the case a little more difficult, and it could make you as a surgeon more prone to making a mistake. But overall, pretty much all the brands out there are solid. As far as the material, there's a few different types of materials you can use for hip or knee replacement, and there's not really too much difference in outcomes based on that. Both knee replacements are typically going to be a metal tibia, a metal femur, and a piece of plastic in between with a piece of plastic for the patella. And for hip replacements, it's going to be a metal femur, a metal acetabulum or shell, and then a plastic or a ceramic liner and a ceramic or a metal ball. And all have done well in studies, and surgeons can kind of pick what's right for what patient based on demand or needs. Next question is, I had a gel 3 injection in my knee, but it caused more pain than before. Would cortisone be better? So we talked previously about the gel injections and the cortisone injections. Treatment for arthritis from a non-operative standpoint is essentially trial and error. So if you have a knee pain, try Advil. If it helps, great. If it doesn't, move on to the next thing. If the pain persists, try therapy. If that doesn't work, then stop therapy. If you're having pain and you try a cortisone injection and that works, great. If it doesn't, you try gel shots. So unfortunately, it's not that anything's better or worse, it's just that they're different, and you really have to see how you respond. Some people will swear by cortisone, others will swear by gel 3 or the hyaluronic/visco supplementation injection. So everybody's different, and unfortunately it just comes down to trial and error. Question from Jen, why don't they do hyaluronic acids on joints other than the knee?
That was
mainly because it is not FDA approved. So it's hard for insurance to get approval. I have done a couple of hyaluronic acids in injections in hips. Didn't find great results. There are people that would disagree with that statement, but basically it's not widespread because it's not FDA approved, it's not covered by insurance. And the injections can be costly. We're talking like $1,000 or so at times for a round of injections. Let's see. The question from Gene is, do you always try to do partial replacements first? So I didn't get into this kind of because I usually do put partial knee replacements in my talks, but I was kind of adding the COVID stuff, so I wanted to keep it, at a reasonable time. So a partial knee replacement is a great option for certain patients who have arthritis limited to one part of the knee. And so if you have arthritis limited to one part of the knee, a partial knee replacement can actually allow a surgeon to replace that part of the knee with metal and plastic and leave the rest of your knee natural. So the hope is it feels like a more natural knee and has better range of motion. Great procedure. So we don't always try partial knee replacements first. We use partial knee replacements when they're indicated, when it's the right patient for it. And usually you can make that diagnosis with an x-ray. Next question is there another injection other than cortisone or gel that is on the market? There are other injections out there. Unfortunately, they don't have great evidence or data. So platelet-rich plasma is something you may have heard of. It's where they take your blood, they spin out the platelets, and or they spin out the plasma, and then they inject that into a body part. The theory is that those are healing parts of your blood, and that would actually kind of heal the damaged surfaces. The science has not backed that statement up, but those injections can provide pain relief. So they are an option for patients. Additionally, stem cells are another type of injection. Stem cells are the cells that really you start from, and your body divides into eye cells, heart cells, muscle cells, bone cells from these stem cells. So there's some theory that if you inject stem cells in a body part, then those cells will develop into whatever cell you want, and then that'll fix whatever problem. So if you inject stem cells into a joint, those cells will become cartilage, and then you're good. You have all this cartilage that was gone, and now it's back. And so that hasn't really been backed up by science either. But there are plenty of people out there, or some people out there doing these injections. The problem when something's not backed up by good data and not FDA approved is that it won't be covered by insurance. So these stem cell injections, I've heard of people paying $10,000 or $15,000 for injections that you're not even sure if they're going to work. So that's a tough sell. Not something that I do, but it is out there, and it's an option. And I hope that down the road we have some good studies that hopefully prove that these are efficacious and they can help our patients. How do we determine when it's time to replace a knee? Someone has an arthritic hip and a knee and wondering how to make that decision. And that's a great question, and patients ask me that every day in the office. So basically, once you get the diagnosis and that's what you have, arthritic hip, arthritic knee, and it's bad enough that you'd benefit from a knee or a hip replacement, your surgeon's going to tell you that. And then it's really just a question of you kind of weighing the risks and benefits and the options. And so, if you say, I have bad knee arthritis, but I can do everything I want to do and I'm not limited, well, then you don't need to replace the knee. But if you say, well, I have bad knee arthritis and my whole family went on a walk on the boardwalk last week and I didn't go because my knee was hurting, that may be important to you. And that may be a time where you say, okay, I'm just doing this because I want to be able to walk on the boardwalk with my family. So it's really an individual decision based on your needs, your desires, your lifestyle. And the patients, they know when it's time, and they usually end up telling us. Next question, can I get an evaluation virtually at this time? And how is imaging scheduled to reduce COVID risk? Yes, you can get an evaluation virtually. We are doing telehealth visits through our EMR. And what we do, if we need imaging, if you've had imaging before and we can access it at our local hospital, that works. If you can bring in the disc, if you've had imaging, and we can put it on our system and the surgeon can look at it, once he or she is having the consultation, that works. Additionally, we can bring you into our offices and get an x-ray and then, see you later that day or the following day or whatever. So there are ways around this to decrease COVID risk. I can tell you we're doing a good job with social distancing in the office, but it does seem like people are more and more comfortable coming into the office. How do we determine when it's time? Well, I think we did that. Next question was, if a total knee is required for a second joint, do you match the second new joint with the first system? Typically, that's commonly what's done, but for any number of reasons, it might not be. Like I said, there's really no difference between the implants. So if you had, let's say, a Johnson & Johnson DePuy knee on one side and a Smith & Nephew knee on another side, you'd be just fine. There'd be no increased risk. Paul is a runner, and he has right hip and left knee pain, though the knee pain is near the skin at a specific spot. No treatments yet. Is there any advantage to doing other treatments before surgery? Is surgery on the knee likely warranted? That's a great question. And I would say for you, Paul, you haven't had an evaluation. So definitely get evaluated. It could be something as minimal as tendonitis, and some rest and anti-inflammatories would help you. Could be something more severe and, like bad arthritis or something like that. And then again, you want to maximize the non-operative treatments. Surgery is a big deal. So you don't want to jump right to surgery. So if there's non-operative treatments, injections, medications, therapy, use those first. And then, kind of like I said before, wait to decide to have surgery until, it's adversely affecting your quality of life. Question about, have you heard of the UBX010 trial? I may have, and if that is referring to a medication that is not approved by the FDA, can't really comment on it, but I'm not sure if I'm talking about the same thing that Gene is talking about. Is age a risk factor if a patient is in good health? Absolutely, age is a risk factor, but age is not a limiting factor. So I wouldn't say to somebody, hey, you're 95, you can't have your joint replaced, or you're 45, you can't have your joint replaced. I would say, well, what are your expectations? What do you want out of life? What's your quality of life like with the arthritic joint? And then how healthy are you? There are some 95-year-olds that are fit as a fiddle and are actually better medical candidates than some 70-year-olds. Vice versa, there are some 45-year-olds that are not good candidates. So when we talk about surgery and risk factors and who's a good candidate for surgery, what we do as surgeons, we can operate on anyone and, do the mechanics of the surgery. But what we do as surgeons, our job is really to minimize risk. So we take each patient, whether you're 45 or 95, and we say, okay, what are the things that are risk factors for this patient to have a bad outcome? And then we work to get those better and optimize those prior to doing a surgery. Let's see, a lot of great questions here. Since younger patients are getting joint replacements, how long are replacements lasting, and when do you typically need a revision? This is a great question. We have a lot of great data showing that hip and knee replacements last 20 years, 80 to 90% of the time. That doesn't mean they're failing year 20 and day one. It just means that it's hard to do a study where you follow patients for 20 years. And Lisa's absolutely right. We're seeing more arthritis in younger populations, and people don't want to suffer and they don't want to struggle. They want to live their lives. And so we're doing surgery in, knee replacement and hip replacements, and sometimes people in their 30s even. And so what are the chances that person might need a revision? The implants are really good at this point. The plastic is really good. That typically was the limiting factor in the 90s and the early 2000s. So we don't know. What I do is if a patient's under 60, I'll usually tell them, or I'll always tell them, look, you may at some point need another surgery on this, but the hope is now to kind of give you your life back and let you be functional and enjoy it. Next question is, I have 2 bad hips. Can I get good results from surgery recovering, rehabbing on another bad hip? Is bilateral hip replacement safe? Yes, you can have good results from surgery recovering on having one hip or knee replaced with the other one being bad. Bilateral hip and knee replacement is safe, but it is a lot of surgery and there can be blood loss, so it's not for every patient. There are a lot of reasons to do, one at a time. There are some reasons to do both at the same time. Can you use Voltaren for hip pain? I'm so glad Bruce asked about Voltaren. Thank you, Bruce. Voltaren is a great medication that can be taken orally. It's a pill form, but recently there's a Voltaren gel that you can rub on your kind of affected arthritic area, and recently that was FDA approved to be over the counter. So it's a great option as opposed to taking like a pill like a diclofenac or an Advil or a Motrin, which could cause systemic issues like with your GI tract or your kidney. Voltaren gel is topical. It's over the counter now. It used to be prescription. And you can basically take some of the gel, 2-3 grams, and rub it on an arthritic joint or painful area, and it can provide some good relief. Is it recommended to do certain exercises before a replacement as tolerated to make recovery easier? Absolutely. This person is asking kind of about prehab. And, physical therapy before surgery to prepare for surgery specifically is typically not approved by insurance. But what we do at the Rothman Institute, we have some, or what I do, is I have some handouts which I give patients and tell them to start doing the day they sign up for surgery. So that's something that's helpful. And we have in the past, and I think we will in the future, have an online platform with an app that's going to guide patients through some of these things as well. So the best answer for this question though is the better shape you're in before surgery means the easier recovery is going to be and the better candidate you are for surgery. So that's really a great idea. If you're considering surgery and you have an arthritic hip or knee, to be doing exercises to get in better shape right now. What about supplements like glucosamine and chondroitin? This is kind of a controversial question that's been around forever. Glucosamine and chondroitin are the building blocks of cartilage. So some theory is that if you eat or ingest those supplements, that then your body will have those building blocks and therefore be able to make more cartilage. That is not how it works at all. But these supplements can provide some anti-inflammatory effect, which helps people. So if people want to try supplements, there's ginkgo, there's capsaicin, there's glucosamine, chondroitin, cherry tart juice. They're all out there, which are, a lot of them are antioxidants that can help muscle or joint pain. And if you want to try them, that's great. But there's no guarantee they'll work, and the data isn't great that they will work. A lot of really great questions. Next question is, what are the benefits of cement or cementless joints? That's a really technical and a really great question. With knee replacement, typically in this country, the implants are grouted onto your bone with a bone cement. There is an option to do it completely cementless without cement. With hip replacements, typically in this country, they are press fitted, meaning the implant touches the bone directly and the bone goes into the implant. In the past, the implants for hips were cemented in, meaning they were grouted into the bone, just like the knees are currently now. So with hips, most hip replacements in this country are going to be cementless. With knees, it's a newer technology that's kind of gaining popularity. At this point, there have been no studies that have proven benefit of cement versus cementless. Basically, either work as long as the surgeon does a good job. I think those are all the questions I see.
Awesome. Thanks, Dr. Saxena. If anybody has any
great questions.
Yeah, if anybody has any additional questions that they didn't get to put them in the chat, feel free to reach out to me directly and I will work with Dr. Saxena to get the questions answered for you. But again, if anybody joined us late, Dr. Saxena, one of our joint replacement surgeons, seeing patients at our Mercerville, Pennington, and Princeton locations. We are currently doing, as Dr. Saxena mentioned, televisits if anybody is not safe with coming to the office, and we also seeing patients in person in the offices as well. I will send the recording of the presentation out to everyone tomorrow. So I know a couple people were having issues with sound in the beginning. I apologize. I think some of you got it figured out, but if not, again, I will send the whole presentation an email tomorrow with some scheduling information and direct contact information for Rothman in case anybody has any questions or needs to schedule an appointment. But again, I just wanted to thank everybody for joining us this evening. Hope everybody stays safe, and we hope to get back to normal soon. Thanks, Dr. Saxena.
Thanks, everybody. Thanks, Jen. Everybody have a great night. Stay safe.
Thank you.